Morning. Today I'll talk about lateral epicondylitis, also known as a tennis elbow. So, lateral epicondylitis is a overuse injury that caused by eccentric overload at the origin of the common extensor of the forearm. So that cause tendinitis and inflammation of the extensor carpi radialis brevis. So the origin of the extensor carpi radialis brevis (ECRB) originates from the lateral humeral epicondyle and then it inserts at the third metacarpal, base of the third metacarpal. So the innervation is by the radial nerve, and then there are other common extensor that originates from the same place as well, which is the extensor digitorum, extensor digita minimi, extensor carpi ulnaris, and enconius. Okay, so the epidemiology, it affects around 50% of tennis player due to the risk factor is due to poor swing technique, heavy racket, or due to a poor hand grip, incorrect grip size and high string tension. Also, those laborer who repetitive doing heavy lifting and any repetitive movement over work that involve the repetitive movement of the elbow. So symptom wise, usually patient will complain of pain over the lateral epicondyle, and then usually pain worsen during resisted extension of the wrist or the finger, and then the pain varies from very mild pain and to severe pain which affects the sleep. And then patient might also complain of a reduced hand grip strength. And then for physical examination, usually we look at any muscle wasting, which can indicate a chronic tennis elbow or those with a previous multiple steroid injection. And then for range of motion, usually is full, and pain usually will be aggravated during wrist extension or when forearm pronated with wrist maximal flexion or extension of the middle finger, extension of the third finger. And then we can do a special test. There's two special tests for the tennis elbow. One is the Mosley test, which is the extension of the third finger, and a Cozen test, which is the extension against resistance of the wrist, which will aggravate the pain over the lateral epicondyle. And then for next will be radiology. X-ray usually have minimal help in the diagnosis, but can look for bone calcification or arthropathy over the bone, and then of course to rule out fracture. And then for MRI, can look for any thickening of the tendon, edema, and any tendon tear over the origin. And then for ultrasound, same, we look for any edema and hypoechoic over the tendon area. For treatment, is divided into non-operative and operative. Non-operative can prescribe patient with NSAIDs and then ice compression, and then also can offer patient acupuncture, extracorporeal shockwave and ultrasound therapy. Another one is splinting, can do a counter force brace, or also the elbow POP. Can keep for at least 4 to 6 weeks, or depends on progression of the pain. And then also for the pain, can offer injection, steroid with local anesthetic, or also PRP injection. And then lastly, if pain does not resolve with all this conservative management, but usually 90 to 95% will improve with conservative management. But if still not improving, can actually proceed with operative management where orthosite can do a debridement of the ECRB tendon and a decompression of the area. That's all. Thank you.